Pressure ulcers. Any soft tissue injury resulting from unrelieved pressure over a bony prominence is defined as pressure ulcers. They are also randomly spoken as decubitus ulcers or bed sores, but they are not the accurate term for pressure sores, and the exact word to be used to describe these injuries is pressure ulcer or pressure sores. Overall, 9% of all hospitalized patients develops pressure sore, and out of which three types of patient population predominate, and those belong to patients in acute care settings having neurological, cardiovascular, and orthopedic issues, patients that are living in nursing homes that have poor nursing care, and the third important category are the paraplegic patients. This is a list of risk factors that are responsible for development of pressure sores, development of pressure ulcers. Age. Patients belonging to extremes of age, like patients who are in a very high age group or very low age group, are especially prone to development of pressure sores. Literature have shown that male gender is also a risk factor for development of pressure sores, as most of the patients in nursing homes and in the hospitals are male. Poor nutritional support. Patients who are in debilitated state are more prone to develop pressure ulcer. Immobility is also one of the common risk factors that can lead to development of pressure ulcers. In the next few slides, we will discuss the pathogenesis of how does the pressure ulcer develop. We will see why immobility is one of the important risk factors in the development of pressure ulcer. Compromised blood flow. Patients belonging to those group that have poor blood supply to a specific area, or patients with peripheral vascular disease, in which the blood flow to the area of those pressure points where these pressure ulcers are formed will lead to delayed wound healing. So any disease that leads to compromised blood flow to those areas is a big risk factor in the development of pressure ulcers. Fecal and urinary incontinence is also one of the risk factors that leads to development of or pressure ulcer, and in those patients who already have those pressure ulcers, they can lead to contamination of these ulcers, leading to increase in the severity or grading of the pressure ulcer. Patients who have altered sensory perception, they are also at risk of developing pressure ulcers, which means in a normal human being, when they go into sleep or they are lying on a bed during sleep, the sensory perception, if it's in a normal person, the neurological system acts in such a way that after a prolonged period of time, the person naturally changes his position on the bed, or to relieve the pressure over the bony prominences. But those patients who have altered sensory perception, this mechanism is lost, and those patients cannot on their own change their position, leading to prolonged pressure on a specific point that can lead to development of pressure ulcer. And patients who have loss of sensory perception also, they are unable to to realize the pressure points, and that would lead to prolonged pressure on over the bony prominences that will lead to development of pressure ulcer. Moisture is also one of the biggest risk factors in development of pressure ulcer. The moisture can be because of the patient's own sweating, atmospheric conditions, or from urinary fecal incontinence that will lead to the circumstances that will promote development of pressure ulcers. Friction is produced when the two surfaces move across each other. This results in the loss of the superficial layer of epidermis, and this and if there is moisture, the frictional forces would require less force to create these loss on the to create this breach in the superficial layer of the epidermis. Shearing force, on the other hand, is a force when two layers of the body move in opposite direction. Like if the skin moves in one direction, and while the patient is lying on the bed, and the bones and the muscles, they tend to not to move, or they move in opposite direction, this shearing force would lead to the rupture of the perforating vessels coming from the muscles to the skin. That will tend that will lead to development of poor wound healing in those areas because of the damage to the blood vessels. So this is also a risk factor in the development of pressure ulcer. The mental status is also very important in pressures ulcers, because if the patient is mentally sane, he would be able to understand the instructions how to manage himself when they are lying on the bed or sitting on in one position for a prolonged period of time. But if the patient's mental status does not allow him to understand the the risk involved, he might not be able to comply with the instructions, and that will lead to the development of pressure ulcers and delayed healing of it. So coming to the pathophysiology, pressure causes mechanical damage to the tissues, which results in occlusion of the blood vessels, leading to ischemia, which leads to ulceration and necrosis of the tissues. So the tissue's tolerance to ischemia can be modified by different extrinsic and intrinsic factors, which are basically the risk factors which we have discussed earlier in the previous slide. The extrinsic risk factors are moisture, friction, and shear, and the intrinsic risk factors are the factors like nutrition, anemia, age, decreased sensations, decreased mobility, decrease in the mental status of the patient, and decreased autonomic control, incontinence, and infection. There is an inverse relationship between the amount of the pressure and the time required to cause pressure ulcer. The normal capillary pressure ranges from 16 to 33 millimeter mercury in different segments of the body. So any external pressure of more than 33 millimeter mercury will occlude the blood vessels. So different studies were conducted, and the conclusion was that if more than 70 millimeter mercury pressure is applied for more than 2 hours, it will lead to ischemia and irreversible tissue damage. So that tissue damage or the pathological changes that occurs will first affect the muscles, and then they will affect the superficial soft tissues later on, and skin is the last to be affected. So how to deal with these pressure ulcers is by prevention, and which means that intermittent temporary relief of pressure is essential to prevent this irreversible tissue damage. Pressure ulcers occur in the following areas as shown in the picture. Depending on the position of the patient, they can occur in the sacral area, greater trochanter, in the ischial tuberosity, in the malleolar area, heal in the area of the femoral head if patient in the lateral position or in the area of the scapula. National Pressure Ulcer Advisory Panel have staged pressure ulcer into 5 different stages depending on the increase in the severity. Stage 1 is non-blanchable erythema. Stage 2 is partial thickness skin loss. Stage 3 is full thickness skin loss with damage to the subcutaneous tissue, including muscle and in which muscle and fascia are not affected, they are spared. And stage 4 is full thickness skin loss with damage to the deep tissues. And the one of the stages is called unstageable pressure ulcer, in which the ulcer is obscured by covering scab of or eschar, and we cannot judge how deep the tissue damage is. So this is a picture showing stage 1, which is a non-blanchable erythema. You can see the skin is intact. Stage 2 is partial thickness skin loss as shown in the diagram. This is stage 3, in which there is full thickness loss of skin and damage to the subcutaneous tissue, but the muscle and the fascia are spared. If the ulcer goes deep and the muscle and fascia are also affected down to the bone, it's considered as stage 4. So now let's consider a few pictures of real-time patients. As in this picture, you can see a patient with an ulcer on the gluteal area and the sacral area. Here, this is stage 2 ulcer. As you can see, there is partial thickness of loss of the epithelium only, so it's stage 2. This picture shows a sacral ulcer, that is stage 1, in which the skin is intact and there is only non-blanchable erythema that is visible. This is stage 3, in which there is full thickness loss of skin and involves subcutaneous tissue, but the muscle and fascia seems to be intact. This is considered as an unstageable pressure ulcer, in which we cannot stage because of the presence of this eschar or necrotic patch of skin. So once this patch is debrided either surgically or with dressing, only then we would be able to grade or stage this ulcer. So this at the moment is considered as unstageable pressure ulcer. This is stage 4, in which you can see the skin is affected along with the subcutaneous tissue and down to the muscles, and even the bone is also seen in this pressure ulcer. So this is stage 4. So how to manage these pressure ulcers? The most important thing is prevention. So, and in prevention, all our goals are towards the intermittent temporary relief of pressure to prevent this irreversible tissue damage. So the so the most important point is education of the patient, of the family, and of the nursing staff taking care of the patient. And important points to teach that the skin should be cleaned and dried regularly. Any particulate matter should be removed from beneath the patient that can lead to development of ulcer. There should be proper cleaning of urinary and fecal habits, and this should be done to avoid any gross contamination. The use of special cushions and beds and wheelchairs can be taught by can be taken care of by the occupational therapist. By OTV means occupational therapist, which can be taken on board to design these special kinds of sitting or lying beds. Different low air loss beds and mattresses are available, and fluidized beds are available now that can help relieve the pressure while the patients are lying on the bed to decrease the incidence of development of pressure ulcers. As pressure is the most important factor, and as we know that the time limit is 2 hours, so patients that are bed bound should be repositioned every 2 hours to avoid continuous pressure of one point more than 2 hours duration. And those patients who are on wheelchair, they should have a relief of they should lift themselves off the table for every 10 seconds for every 10 minutes duration if they are wheelchair bound, or for 10 minutes for 2 hours if they are on a wheelchair, in in order to avoid continuous pressure on one point and any pressure related ischemic injury leading to the development of pressure ulcer. Shearing and moisture forces should be minimized. The patient's medical condition should be optimized. If patients are anemic, the hemoglobin should be improved. If they are nutritionally not in a good shape, their nutritional requirements should be improved to in order to provide them with a good background for the healing to occur or in an early manner. The treatment of the patients who have developed pressure ulcer is basically multidisciplinary, in which plastic surgeons, wound care nurse mm, have major role in the management, in the look after of the wound, and different applying different sort of dressings, and whether to go for surgery to debride and coverage of those wounds. But it's a team work, and plastic surgeons need the help of internal medicine to medically optimize those patients, as these patients might be having different conditions like diabetes, cardiovascular, or cerebrovascular issues that needs to be taken care in order to provide a good platform for those patients to heal. There is role of urologist to create urinary diversion if there is need and of that to prevent frequent soiling or of the beds. General surgeons might be also called on board in cases where fecal diversion is needed. Dietitian is also an integral part of the multidisciplinary team that will help in improving the nutritional status of the patient. Physiotherapists and occupational therapists are also an integral part of our team that helps in designing different sorts of mattresses and cushions to avoid pressure on those areas. And the role of physiotherapist is to help relieve the spasm that have developed in most of those bed-bound patients, because if they develop contracture, that will lead to new areas of pressure that will then lead to new areas where pressure ulcers can form. So, the treatment is mostly based on the stage of the ulcer and the condition of the patient at that particular time. So wherever possible, the predisposing factors leading to the development of pressure ulcers should be corrected. and the preventive measures which we already discussed must be placed not only pre-operatively if we are planning to do a surgery, but post-operatively as well to prevent recurrence. Patients with deteriorating conditions are generally not good candidates for surgical reconstructions. Patients who are expected to increase their mobility are generally treated conservatively, as their ulcers will improve once the pressure is relieved. And surgery is usually best suited to well motivated young patients, patients that are clinically stable condition, and patients who will adhere to the post operative preventive measures. We have different types of dressings available to be applied to these ulcers, and vacuum assisted closure is one of the dressing that can be used as a useful adjunct to speed healing in appropriate cases. We should rule out and treat underlying osteomyelitis if there is. In terms of the surgical treatment, if the patient's condition is not fit to go for surgical debridement, we go for bedside debridement on the bed with minimal debridement every day, or we have certain dressings that like silver sulfadizine that can be applied, that can act as a chemical debriding agent. And although the speed with which these chemical agents work as a debriding tool is delayed, but as patient's conditions might not permit early surgical debridement, these dressings are very good to achieve the same goal, but in slightly longer duration. If the patient's condition is fit to undergo surgical debridement, ideally these patients should be debrided in OR. And once the debridement has taken place, vac dressing is applied, and then next comes the planning for soft tissue coverage, which can be done either with local pedicle flaps, or if the the defect are not that big, even sometimes the vac dressing itself can be enough to help close these wounds. The important principles to note while doing surgery for such pressure ulcers is that there should be an adequate wound excision that needs to be performed, and this should include excision of the surrounding scar and underlying bursa and bone and soft tissue calcifications that are present. There will be a resultant dead space that needs to be obliterated. The surface of the defect should be reconstructed with a durable skin. When designing flaps should be designed in such a way that our future options are not wasted, and the flaps needs to be done in such a way that they can be re-advanced in future if needed, in cases of recurrence. If possible, the territories of the future potential flaps should not be violated, and the flap should be designed as large as possible. The final closing line should be away from pressure areas to avoid recurrence, and large drains should be inserted under the flap and left in place for a few weeks till complete healing has taken place. So that concludes the section of pressure ulcer. Thank you very much.